Hey guys, Caitlin here, and I am a newly graduated PA. And last week I talked about everything you need to do after PA school to be successful. And a couple things I touched on were taking your boards, applying to your license, listening to podcasts that might be pertinent to your field, signing up for societies either for continued learning or for getting CME opportunities, and finally relaxing. And last week, I told you we would talk about some of the updated guidelines for emergency medicine. And I've trimmed it down and took out the main points that were talked about in that Medscape article I gave you last week. If you still want the article, here's the link now. But first, let's get started. I want to talk about atrial fibrillation. It is super common to see it in the emergency department, and you can be either dealing with it chronically or first diagnosing it there. It can be the main problem the patient's dealing with, or it can be a side problem from another comorbidity. When it comes to diagnosing AFib, you should probably order an EKG, an echo, and a TSH. If you hear an irregular rhythm on auscultation or you see it on the telemonitor, ordering an EKG will confirm the diagnosis of AFib. An echocardiogram will look for the possible cause of the rhythm. Mitral stenosis is super common here. And a TSH can also look for a possible cause of the rhythm, and it can cause many other things to go wrong in the body. So next I want to talk about the CHADS-VASc score. Now, this has been used for atrial fibrillation for a while now, and it used to just be called the CHADS score. Updated to CHADS-VASc a while ago, but now the new guidelines are taking out one little thing in it. But we'll talk about that in a second. Here's a review of the CHADS-VASc score. Now, everything in the CHADS-VASc score stands for either a comorbidity or a past medical history of the patient. And if they have these things, then they get points based on their score. Now, you can use this in the treatment for atrial fibrillation. A score of 0 means that no further treatment is necessary. A score of 2 or more means that anticoagulation is required for treatment. Now, in the past, a score of 1 meant that you could use an antiplatelet or anticoagulation in the treatment of AFib. But the new guidelines vote against the use of an antiplatelet. And I'm sure you're asking, what anticoagulation? Well, the direct thrombin inhibitors, the factor XA inhibitors, and warfarin are still recommended. But if your patient has chronic kidney disease or they have valvular causing AFib, then they vote for warfarin in the use. If your patient is hemodynamically unstable, cardioversion is still the recommended treatment plan. And also remember, calcium channel blockers and amiodarone are also indicated in AFib patients. Calcium channel blockers, although, are contraindicated if the ejection fraction is less than 45%. And amiodarone is indicated for symptomatic AFib, yet not unstable enough for cardioversion. I would consult cardiology before amiodarone is prescribed for any patient. Now next I want to talk about patients with acute coronary syndrome. A lot of patients come to the ED with chest pain, then diagnosed with a STEMI and must go to the cath lab as soon as possible. I want to talk about the guidelines of the procedures that you must do before a percutaneous coronary intervention, or also called PCI. Now, some of the guidelines are newer and some of them are older. An old guideline, certainly worth repeating, is if a patient is on metformin, and if they are, ordering renal function tests before the procedure and also hanging a normal saline bag in the ED prior to the procedure has been long accepted guidelines, like I said before, worth repeating. Now, some newer guidelines are also before the procedure, you should give cangrelor if the patient has never received a P2Y12 inhibitor, and also glycoprotein 2B3A inhibitors should also be given prior to the procedure. And lastly, I want to talk about heart failure. A lot of patients come to the emergency department for an acute exacerbation of heart failure. If it is a new onset heart failure ordering an EKG can show a coronary artery blockage, possibly causing this new onset. Now, ordering a chest x-ray is also very important to rule out other pulmonary causes of the possible shortness of breath symptom associated with heart failure. Now, if you want to talk about the treatment of heart failure, loop diuretics are still the go-to medicine in reducing pulmonary congestion associated with heart failure. But if they have concomitant hypertension with a mean arterial pressure greater than 90 millimeters of mercury, then nitroglycerin or morphine can also be used to reduce that pulmonary congestion. Now, the last thing I want to point out is not emergency medicine specific, but I found it super interesting. SGL2 drugs, or the diabetes drugs that end in the suffix of flozin, are now recommended for patients with diabetes with concomitant cardiovascular risk. And that's it, guys. But just remember, I only did a review on 3 of the topics that were included earlier in the link I provided for you in this video. If you want to do more reading on the new guidelines of emergency medicine of 2018, click that link. See you next Wednesday.